Greetings, everyone, and this is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, health systems, and other healthcare organizations around our land. Our goal is to identify as many of these bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you have not subscribed to Bright Spots in Healthcare, I encourage you to do so. Each week, we bring great leaders together, like the ones you see in front of you today, if you're watching live via Zoom, and they provide all kinds of great ideas, great success stories. We've got years of episodes. A lot of those episodes do fall into what I would call the evergreen category. So if you want access to all that information and all those great guests, I encourage you to join. If you want to check out some of our guests or just overall what the show is all about, you can certainly go to brightspotsinhealthcare.com. But we are in any podcast app you use, we are probably there. Just type in Bright Spots in Healthcare, and you will find us. Okay. Our topic today is certainly one that is very current and on everyone's mind and super important, and that is the convergence of pharmacy and the Health Equity Index in 2024 and beyond. And we have a tremendous group of roundtable experts that we are putting forth in front of you today. We're not going to, as we never do, we're going to not give you their full bios. We're going to actually post links to those both in the live Zoom chat and in the show description on your podcast app, so you can get a view of the depth of knowledge and experience you're about to receive. But I will let you know their names, titles, and organizations, and we'll bring them in sort of as I ask them questions. But in brief, we have Amin Serehali. He's the Senior Vice President and Chief Data and Analytics Officer up at Independent Health up in Western New York, my home away from home. So shout out to 716. Logan Fox, who is the Director of Enterprise Quality Improvement Programs at CareSource, one of the most innovative Medicaid and dual plans in the nation. And Kempton Presley, the Chief Strategy Officer at AdhereHealth, that is doing some incredibly cool things for health plans across the country. And we're going to hear from all three of them on stories that they have to share with you that hopefully you can learn from and maybe even clone as we go out through today's conversation. I also encourage you all to help me co-moderate if you're attending live using the Q&A module. We have a team behind the scenes. If you're watching live on Zoom, you see their names there. They're all monitoring the Q&A module. They're going to cue me in for questions I should be bringing in live throughout the discussion, and some of those questions we'll just type in and post to everyone. So definitely feel free to moderate and react to all the Q&A that's going to go on later on throughout the show. All right. A quick thank you to our sponsor for today. We cannot do this show each and every week without the incredible corporate support that we receive from innovative companies throughout our industry. And today we have a brand new partner in crime to Bright Spots in Healthcare. The organization is called AdhereHealth. They leverage the combination of unique technology and services that drive member engagement and adherence performance in the hardest to reach members like no other solution in the market. You could check them out at adherehealth.com. I'll tell you a little bit more about them later on in the show. All right, we're going to start with the aforementioned AdhereHealth. I usually don't start the first question with our sponsor, but I think for purposes of this discussion, I want to get into sort of adjustments that organizations have to make to policy and regulation changes, because that's paramount to the topic we're covering today. And incidentally, folks, I've kind of organized the show into 4 segments today. We're going to talk about pivoting and adjusting and innovating around regulatory changes and policy changes. Then we're going to talk a lot about predictive data analytics and everything that falls under that as it relates to HEI and pharmacy. We'll then get into sort of innovation and questions tied to innovation, and then about implementation and blueprinting some of the great ideas you're going to hear today. So we have a pretty packed agenda, pretty well planned, and I hope you're going to get a lot out of it. So back to the questions. Kempton Presley, Chief Strategy Officer at AdhereHealth, welcome. Kempton, I want to talk with the IRA, the Inflation Reduction Act, and Medicare Part D, and how our plans or how can plans make this actually a positive and use the member cost savings legislation to improve outcomes and create a better pathway to earning 4 or 5 stars.
Sure, absolutely, Eric. Thank you for having me, and it's great to be here with an esteemed crew. The legislation that's just come out obviously has significant kind of affordability ramifications as it relates to medications and the economics associated with them, making it easier for members to get medications, and making it such that that particular barrier to adherence and compliance is removed. That said, plans are seeing that that's just one kind of component of the risk prism. Affordability is just one component of the risk prism that affects whether a member is taking their medication or not. And we find, working with plans that they see medication use as an important proxy to understand the entire behavior of the member. So with this legislation, there's significant emphasis on improving social vulnerability and driving change and kind of endemic issues that patients and populations may experience. And what plans are seeing with medications is that can be the tip of the iceberg that reveals significant details about a patient's particular situation. An example would be we have a plan that has found through analytics that their patient wasn't taking their statin consistently, and it showed something about their behavior where they weren't showing up to get their meds. And upon looking deeper into that particular patient situation, they found that there was a massive transportation barrier for that patient, so much so that they hadn't left their house in 2 or 3 months. And so that showed a significant social disconnectedness situation. And in addition to, obviously trying to make sure that that patient got transportation to be able to go get their medications, we worked with the plan to be able to help them establish Zoom calls for that patient, be able to connect with community resources and bridge that social connectedness disconnect that existed. And that all fits within the legislation that's come out in terms of focusing on vulnerability and removing barriers.
Like that. Can you tell me a little bit too about just the overall methodology that you think health plans need to be taking as it relates to just choices they make every day? I know when we were talking prior to the show, you kind of were talking a little bit about the approach, how there's all kinds of decisions that go into an individual, personal decisions that an individual makes going about their own treatment and care. And the whole choiceology methodology, as you call it.
Right. No, we did talk about the choiceology. Plans see that medications are oftentimes a more revealing proxy as it relates to what a patient's day-to-day decisions are than any other healthcare setting, because you think about the fact that more people use medications than other settings throughout the healthcare continuum, and that involves personal choice and coordination with different parts of the continuum on a daily basis. So you can find a lot out about a patient's experience and their particular settings and surroundings and their care team simply by looking at how they're using their medication. You can see that through the claims. You can see that through the clinical record. You can see that through analytics, and then pull deeper on that, pull that thread harder to really understand what their choiceology is, and allows you to put together a behavioral framework and the right nudges to be able to both kind of close those gaps in medication use, as well as change kind of that overall social vulnerability profile.
I like that. It strikes me, and I don't know, Sherry, if we have this already, let me know in chat, but I would wonder if we could ask our audience. We do our best, folks, to make this as interactive as possible. I know it's a one-way call, but ask our live audience, which vulnerabilities first reveal themselves in the medication analysis versus other types of healthcare utilization analysis. If we could maybe create a poll for that and see if we can get some audience feedback. Look at that. That's quick. So awesome. Let me bring in Amin. Amin Serehali is the Senior Vice President, Chief Data and Analytics Officer at Independent Health. I mean, first of all, for those who are maybe not from the Northeast and haven't heard of independent health, just like a 1 minute on who you guys are. By the way, perennial 5-star plan. And then could you talk about how your organization is thinking about this convergence of adherence and HEI?
Well, good afternoon, Eric. Thank you for the invite. We are a small local health plan in Western New York, in Buffalo, New York, and 8 counties of Western New York. But I think we are one of the best plans from a quality perspective. As you know, we have been a 5-star plan. We're the only plan in the nation that has 5 stars in PPO, HMO, and PDP, not just this year, but in the last 3 years. Actually, nobody else can claim that achievement. We're also the #1 plan in Medicaid for the last 3 years in New York State. And we're only 1 or 2 plans in the whole nation that 5-star in commercial. So we have been excelling in quality, and that's not by chance. That's actually our mission, is to provide to our community the greatest quality of care we can achieve. So how are we thinking about health equity and pharmacy? Honestly, we're thinking about health equity in general, not just from a pharmacy perspective. To be honest with you, from a pharmacy, when we look at the differentiation between, for example, the social risk factor members, the SRF members, and non-SRF members, the discrepancy between SRF and non-SRF is the lowest in pharmacy for us. I'm not sure if that's the same for everybody, but actually it's the lowest. Where we started this many years ago, I would say in 2016, when we're looking at quality improvement and we were looking into getting to the 5-star tier, and we saw some clusters of performance. And we created our own methodology. We looked at the census data at the tract level, and we created a formula. Basically, we developed a formula that says, well, if any census tract in the lowest quartile of any measure, for example, crime, education, transportation, and so on, will give you a 1, otherwise you'll get a 0. And what we did by that, created a continuous variable that goes from 1 to 9. That means if you're a 9, that means you're in the lowest quartile, the worst quartile in all these social determinants of health. So we started this actually in 2016, and we were able to find out pretty easily that once you get above 5, we saw discrepancy, very visible discrepancy between the areas that have 5 to 9 of these social risk factors versus 1 to 4. But we really could not understand why. Why, what's driving, and what can we do about it? So what we did after that, it's been a journey for us. Honestly, it's been a journey that started, like I said, in 2016, and we're still learning. So we have made some adjustments. We have created some incentives for providers, and we met at each step, we kept finding problems that we need to solve. So for example, one of the incentives we did back in 2020 is for our IPA incentives. We asked the IPAs to create systems to screen members or their patients for social determinant of health and give us the Z codes. And submit Z codes. And right away, we found a new problem that not everybody has the same tool for screening. And we found out also that back then, there was no Z code for transportation. Now we have one. But also there was another issue that we couldn't even tell if somebody was screened and we couldn't find anything, or was not screened because there was no Z code that said, oh, this person does not have any issues. So we kept learning from there, how can we improve the system? And the other problem that we dealt with is, now what? Now when somebody's, I get a Z code from a provider that tells me that there's a housing issue with this education. Now, what do I do? So that led us to find a much better solution. We partnered with a company called Well Connected in Western New York. It's a Buffalo company. And what the company did is integrated all the CBOs and what they do into one tool that we can communicate with. So if anyone in our community screen a patient or a member for social determinant of health, we can identify their social determinant of health, but we also can refer them now to a partner that can actually help them fix that problem. So do you have a question, Eric? Let me keep.
Nope.
Oh, okay. So we're still learning. So this is, like I said, this is a journey. So we have just last year we screened about 8,000 members. We wanted to screen 8,000 members for the essential plan. And what we learned from it is that only 13% of the members that we called wanted to talk to us because some of the questions are very personalized and people are very proud. So, okay, 13% screening rate is not great if we want to, solve this problem. And the other issue that we found is when we refer to these CBOs, some of them are touching 100% of the people that we refer them to. Some people are touching only 0% and everybody in between. So we haven't solved that problem yet. We need to figure out a way to engage with CBOs and help them understand their barriers too. Some of them may have technical barriers, but they're there to help the community, and we believe that, and maybe they just need a little more help. Now, for the other problem, people don't want to take the screening. So the reason is why? Why somebody that we're trying to help doesn't want to answer questions that from our screening tool, and maybe there's trust issues. Maybe they're, like I said, pride issues. So we're still working on this, but one of the solutions we have identified and we're implementing right now is to create a self screening capability. So if you go to our member portal, and you have an issue with you cannot get food or you need help with diapers or whatsoever, you can take the assessment and you can identify on your own what are the CBOs that can help you solve that problem. So that's one solution we're implementing, but I don't think that will solve all the trust issues. We're also looking into working with community health workers. They don't have to be necessarily working for independent health. We want to go out and find all the community health workers and kind of teach them this is maybe a tool that's free for you that you can use to assess and refer a member to a CBO that can help them with the issue they're dealing with at that time.
So I love this. I want to come back and ask you a few follow-ups later on in the show, but I do want to, you put a lot in there, and I want to make sure I summarize it in a way that is accurate and that our audience kind of, if they're taking notes, I want to make sure they can capture all this down. So first of all, you're looking at both social risk factors, SRFs, and non-social risk factors, and you're putting them, I forget if it was quadrants or quintiles or deciles, but you put your patient populations into sort of risk categories using CMS requirements tied to HEI. I'd love to later on in the show get into how you're getting providers put in Z codes, but we're going to put a pin in that for a second. And then once you're recognizing folks with higher risk, you are trying to get them connected to the right resources. One of the things that you found and you're still looking for a solution for is that of the members that you screen, a small percentage, you use 13%, are willing to engage. And the thought is that some of this information is very personable. There could be a trust issue. So you're going to try to figure that one out. And bringing in CHWs to maybe help with that. And also another potential challenge is, and you're using a tool or a partner called Well Connected. They're kind of like, if I could just create an analogy, tell me if I'm wrong. They're like an Aunt Bertha find help solution
Right.
for just Western New York.
Yes.
And you're able to create resources or find resources for them in the community CBOs. And some of these CBOs are great, and they're following up and touching every member that needs them, and some of them are not doing anything. And there's a bunch of CBOs in between. So there's an issue there, but at least you got something started. And then you have to figure out those are the 87% that didn't take the screen at all. Why didn't they? Tied to trust, pride, and things like that.
Absolutely.
Did I miss
Thank you for
anything?
summarizing.
That kind of summarizes the.
Yes.
Okay, awesome.
Honestly, my point is a journey. We're still working on it. We made some progress, but as we progress, we find issues that we need to tweak. So yeah.
Love it. Got it. Love it. We're going to I want to ask the same question to CareSource. So Logan Fox is a PharmD, so pharmacist by training. He's the director of enterprise quality improvement at CareSource. Very similar, really strong, highly reputable local plan in the Ohio market. So Logan, if you could, just a quick, give everyone, if they're not from this area, a little bit of a 411 around CareSource, and then tell us briefly about how you're thinking about and working on the convergence of pharmacy adherence and the health equity index.
Absolutely. And again, my name is Logan Fox. I'm the Director of Quality Improvement for CareSource, and specifically oversee DSNP quality or Medicare Stars plus pharmacy quality and member rewards. CareSource has been a huge advocate of the role of the pharmacist in caring for the member. We're a nonprofit health plan, and with that, it allows a lot of flexibility and innovation to be able to adapt how we deliver care to our members. We started in Ohio and are most known as a Medicaid plan. I'm the one that gets the privilege of managing quality for the Medicare population, and specifically our dual eligible populations. CareSource was the first healthcare company, Medicaid company, to allow MTM services to be provided by pharmacists directly to our Medicaid members, and we've not stopped from there. We've been growing the role of the pharmacists both in the community as well as in our internal teams, and as a result, we've been very successful in performing highly on our quality measures and initiatives, including in medication adherence. So medication adherence, if you're familiar and on this call, it can be a very tricky and time-intensive undertaking to try to improve those measures. Over the past couple of years, we have really transformed our medication adherence program to multiple percentage points higher year over year. And our final scores, particularly last year, we had improved in diabetes. It was 8 percentage points year over year, 7 or 6 in both statins and hypertension. We did that through a partnership with an outside vendor that we had already had a relationship with, but we were able to build from the ground up a brand new outreach platform that was geared specifically to help our internal clinical pharmacy teams reach out to our members at the right time, with the right messaging, be able to provide that continuous look at what those previous conversations have been. And it really has been transformative. This tool has allowed us not only to serve a smaller, very important and high-risk population in our DSNP population, but it also provides us that scalability to be able to customize how we reach out to different populations, be able to do it on not just STARS measures, but on Medicaid quality measures as well. It's been transformative in how our teams operate and how we actually connect with our members. Another important part of our strategy is making sure that we're all aligned on those same goals. We don't know why this member is not filling their medication on time. We know that that delay is a sign of some potential problems. So we are going into every conversation with open eyes, open mind, open ears, to understand what the needs are of that member. And however we can, we employ resources both in the community with community pharmacies, through mail order or other solutions to make sure that we're connecting our members to the medications right when they need them. And it's been very impactful.
Okay, so from an adherence standpoint, you guys created your own platform that ingests claims and creates automated targeting, and it seems to be working well, and that's at the end of the day the core to everything that you're doing around sort of the convergence, raising the bar around using pharmacy and creating equitable access for all the members that you need to be targeting to make sure that you're reaching the CMS goals.
Absolutely. It's also done in close collaboration with community physicians, community pharmacists, and also our internal care management teams to make sure that the needs that are expressed on any of these phone calls are shared with all of these very important members that play a huge role in the members' care. So as we identify social needs, those needs are shared with the care management team to help them connect to resources. So it's a very collaborative effort. We think of equality as a team sport here at CareSource, and every single one of those touch points is an opportunity to be taking care of our members.
And then you also have to have that clear alignment and communications internally to make sure that you have these goals that you're trying to reach, and you're communicating that internally as well as externally to your providers. It's something that you mentioned also towards the end, right? Important component to it.
Absolutely.
I may come back to you, Logan, and I'm just about how you do that. Like that seems to be a really important, new, but very complex. It seems really easy to communicate with everyone about what's going on, but I'll come back to that in a moment. I want to keep on rolling here. So I want to shift over a bit to predictive data analytics, and just a quick PSA, folks. Q&A module still, help me co-moderate. Also, something I forgot to mention in the beginning, about 15 minutes, you're going to get another email from me. I apologize in advance. I know you've gotten a lot. Just asking for your feedback. What are the content we should be covering throughout the rest of the year? How we could become better. Those of you who regularly attend know that it shapes how we produce the show. So it's a really important touch point for us to have with all of you. It takes 2-3 minutes to complete, and we send it to you before the very end of the show, so you could take the time while you're on the show watching live to be able to complete that. I'm going to bring back in Kempton Presley, Chief Strategy Officer at AdhereHealth. Kempton, how do you approach predictive analytics? And in the most complex patient cohorts, you need to be able to create these personalized approaches to engagement. And it's not as simple as zip code, gender, and race. So, I mean, that gets you probably a certain amount of the way there. But how are you going to the next level? How are you thinking about that for the most complex member cohorts?
Sure, absolutely. And I think building on the good insights of my co-panelists here, there's a systematic way of thinking about kind of how you identify these different cohorts and the different vulnerabilities within each cohort. But then there's ongoing, motivational interviewing and behavioral engagement where you can continue to decorate the analytics you have gathered systematically. And so when you think about those 2 points of view, when you think about the systematic point of view, you can find a lot about a patient based on looking at their pharmacy claims, in some cases their medical claims, other types of HEDIS data, et cetera. You can also reinforce that insight with things like the CDC Social Vulnerability Index, which, as Amin mentioned, you can get at the census tract level and continue to understand a little bit more about that patient. You also have insights about, are they part of a dual special needs plan? What's their low income subsidy status? Do they, fall into a disability category? All of those things that tend to characterize social risk factor if you're using kind of a broad brush. But then as you go deeper and have engagements, and as our plans have engagements directly with their members and their members' providers and pharmacies, they can uncover other insights that aren't systematically as evident. And so an example of that would be, so you think about different types of plans. You think of dual SNPs as the most vulnerable in certain ways. And you think of maybe an egg whip, which is an employer, a retiree type plan, which tends to cover a different type of demographic that may be more, may not have as many vulnerabilities. You don't always want to judge a book by its cover. And so, for example, in many dual SNP populations, we will work with our plans to engage with the member, and those members will be more likely to follow the protocols that we recommend than members in some of the kind of the quote unquote healthy and wealthier plans. But we also see in egg whips and other plans that seem to have a more stable kind of demographic, that there's homelessness, there's substance abuse, there's all sorts of underlying social vulnerabilities that exist in those populations. So what we seek to do with our plans is combine all that systematic data, crunch it together on the front end, and make it such that when we're having the patient engagement, the clinician or the person navigating that patient's care can practice at the top of their license, doesn't have to worry as much about all the clinical details. They're getting that fed to them through technology. They're seeing a comprehensive profile, and they're able to establish rapport with the patient and really connect on that human level and uncover things that may not be evident in a survey. So they're asking things about food, water, shelter, transportation, et cetera, that are in the interest of helping them, referring them to some of those resources that my colleagues here referenced, but like Find Help and other benefit design, related subsidies that may exist for that patient, and establishing that connection with them so that when you begin to talk about medications again, you're already in a place of trust, and you're able to kind of give guidance that can be followed in a different way because you've helped solve for other issues. So, for us, that's really that combination of that front end analytics and making sure you're kind of elevating the person having the conversation, and then the motivational interviewing that the patient is able to experience with those clinicians, as well as coordination with the provider and the pharmacy, and then feeding that all back into the patient profile so you have this continually maturing view of their experience. And you can continue to evolve the program by kind of sorting through all the different experiences and surveillance you're doing to make sure you have all the benefits lined up for where the needs actually are. So kind of speaking to it from a macro and micro standpoint, but that's how I would think about it, and that's how our plans think about it.
Interesting. I want to get independence perspective on that. It strikes me when you were talking, Kempton. So folks know, or who've gotten to know me know, I'm sometimes a little bit critical about what I would call, what people call white papers. They're either too promotional or too technical. But when I was preparing for this episode, AdhereHealth sent me something that they probably would call white paper. I don't know what they call it, but it's called Improve HEI Performance. I do think the first couple of pages of this document, large print, really easy, USA Today kind of reading level, so it's really easy to consume, so perfect for a lot of us who are busy. I missed the USA Today sports page. I used to love that. Sorry, I digress. So Improve HEI Performance is a document that AdhereHealth created. And yeah, the first 2 pages are probably a little bit basic for our listeners and those watching, but then it gets into some really interesting tactics that build upon this conversation we're having today on how HEI is calculated, tying it to how you can convert some of the things that you're doing to the HEI scorings that CMS look at, and some of the tactics, and even a case study. I thought it was exceptionally well done, exceptionally informative. I've shared it with a couple of my folks who are on the plan side in industry. They agreed. So I'm going to send that out to folks who want it. Like I said, it's like a 12-page document, and you could probably just start on page 2 or 3, and then it gets really good for you guys. So I wouldn't send you something if I didn't think it was valuable. The folks over there did a really good job with it. So
Thank
if
you,
you're well, am I giving you credit? Because I don't want to give you credit, but if you're
I mean, you know what? I'm guilty by association.
Okay.
So
Well,
we'll take it.
Let's shift over quickly to back to Amin, Independent Health. How are you guys over there in Western New York approaching predictive analytics in support of your pharmacy and engagement programs?
Uh, Actually, it's very similar to what Kempton already described. I would say some of the differences, the way we think about risk or predictive analytics, we think about it from a three-dimensional model. So, and that three-dimensional model, we call it REI. So R for risk, E for engagement, and I for impactability. So we don't want to just identify the members who have a high risk of not being adherent. First, we want to identify them. We want to and explain why we think they're not going to be adherent. So we want to explain that for sure. But second, we want to say, what is the likelihood they will be engaged with us? They will engage in closing the gap. And the third one is, can we even impact this one? So I'm not a pharmacist. I don't play one on TV either. And I did not sleep at the Holiday Inn last night. But it's easy for me, for even somebody like me who's not clinical, to say that you cannot impact metformin and lisinopril at the same rate, right? Somebody's not taking lisinopril. It's easy to get them to, take that medication to reduce their blood pressure. But metformin comes with a lot of side effects. To bring somebody from 500 milligram to 2,000, you may not be able to do it. So why is this important? Because we all have a limited number of resources, right? So, and you're going to have to optimize your value, the value you get out of the work we do. So if you have to choose between lisinopril or metformin, which one would you do? So do you look at it just from impactability? Do you look at it from a risk? So I think that's where it's really important to kind of converge all those three. So to understand who's not likely to to be adherent, and there's so many reasons why somebody may not pick be adherent. There are some things that we can honestly identify from claims. For example, one of the predictors from claims is just how many other scripts do they have. So that the higher number of scripts, the most likely that you'll be non-adherent for one of them. But others are not easy to identify. So for example, somebody doesn't trust the doctor or the drug, or somebody feels okay without taking the drug because it does when they're not taking the drug and they don't feel bad right away. So those are things that we strive to add to our predictive modeling. So outside the claims, how can we get something that are not easy to get through claims? So that's what I will add to what Kempton already shared.
I like that. I like that a lot. I'm just going to check here to see if what we have for questions. We do have one. I will ask. I'm going to ask our resident pharmacist over there, Logan. And then if Kempton or Amin, you want to jump in, feel free. I'm wondering about the tension between the widely publicized national shortage of pharmacists and asking pharmacists to take on a larger role with a person's healthcare. So I guess they're wondering, like, okay, we want the pharmacists to take a bigger role because, of course, we're short on PCPs and the pharmacists are literally in the community. We know all about that dynamic, but now there's a shortage of pharmacists. So how do you reconcile that, or is there that recognized tension?
Yeah, absolutely. And thank you for that question. So I come from a community pharmacy background as a technician and an intern and pharmacist and then pharmacy manager. And so I lived that tension, and I know that it is very real. And as we're looking for partners and doing innovative programs through corporate partnerships with these chain pharmacies or with individual independent pharmacies or networks of those independents, we're very aware of that. And that is something that we're using as we evaluate the viability of any of these projects and programs, is whether there will be adequate staff time dedicated to making these work. So that's the first thing. The second thing is we also, if the press release is not out yet, it will be soon, we are doing programs that help to incentivize the staffing appropriately. So we're testing a new pharmacy measure along with one of the quality organizations for a vaccination program given by community pharmacists. And so we would attribute those members to the appropriate pharmacies, and as they hit their goals for getting certain levels of their patient population immunized, they will be receiving additional bonus dollars. So the value-based arrangement, testing a new quality measure, incentivizing monetarily, compensating for that higher level of care is all part of our strategy.
Just to dovetail on that, I'm not a pharmacist, but I've got several very, very smart pharmacists on my team, and they guide so much of what we do in our interface with different plans. To us, it comes down to people, process, and technology as a way to combat that need, right? So when you think about people, allowing pharmacists, again, I mentioned practice at the top of their license, so surrounding them with both non-pharmacists who are able to set up engagements for them, who are able to kind of make it such that all of their time spent is flexible to their needs, works within fractional work schedules, et cetera. But as it relates to the process, also making sure that you may not need a pharmacist in the conversation every time, right? You can have the pharmacist designing either the algorithms or the way in which the program works and what needs to be said and the talking points, and have that be, coach others to be able to deliver that message and be part of that motivational interviewing, part of that engagement. And then the technology is sort of obvious in the sense that, by having the right workflow in place, the right software, a pharmacist can have a lot more yield in terms of their particular outreach to, patients, providers, and pharmacies, as the technology allows them to be more effective and efficient.
Like that. It strikes me, because this conversation's been fantastic, that I even forgot really to come back and tell our audience exactly what you guys at AdhereHealth do, though I think it's pretty self-explanatory after hearing a bunch of your answers, Kempton. But just for folks who know, and then Amin, I'm going to come to you with a follow-up question from the audience. So AdhereHealth, if you haven't looked them up yet, they're at the forefront of delivering a purpose-built technology solution designed to elevate pay for performance for all the CMS programs that your health plans, your ACOs are in, and that includes star ratings for Medicare, plus patient experience scores, improve patient healthcare outcomes, optimize cost outcomes for all of their clients. And the company is just really pushing the envelope on efforts that are tied to SDOH and improving that patient experience as a mechanism for improved star ratings. And you could probably hear that through some of the case studies and answers that Kempton's been giving us throughout the discussion today. And they've got this platform called Adhere Platform, and it integrates predictive analytics, intelligent workflow, and proactive multi-channel outreach. It's a combination that is this platform and this process is executed by a team of licensed clinicians. You heard about some of those pharmacists just now, and it's just driving great progress around equitable access and outcomes to adherence and improve quality of care for patients and boost financial impact. They're already working with over 100 health plans, self-insured employers, and risk-bearing entities around the country. So the one thing I really like about them, you're going to get this from this piece I'm sending you, is they're not incredibly salesy. They're very consultative in their approach and how they talk to folks. You don't need to buy their stuff to tap into their expertise. So if you want to meet Kempton or the team and just pick their brain on some of the things they're seeing, I'm happy to make an introduction, and I'll make a personal introduction. I'm not going to give your name out. So if you want to meet those guys, why don't we put up a poll, Sherry, and I'll make a personal introduction. But back to Amin at AdhereHealth. Amin, I wanted to, sorry, my screen, here we go. So getting back to your answer around predictive analytics, do you use tools tied to behavioral science that identify a member's barrier to care? I mean, are you doing any kind of behavioral health approach or even behavioral science approach tying to your analytics that you could share with folks? And if I put you on the spot, it was just a question that came to you when you were answering. I'm happy to move on.
No, I would love to answer the question. So honestly, the models are are not hard to implement. The stats hasn't changed for a long time from the Met perspective. The issue is the data. So how for us to really identify or segment or cluster people based on different behaviors, you really need to have the right data for you to do that analysis correctly. Otherwise, I highly say don't do it if you don't have the right data. So the right data, what is the right data here? What I'm talking about, you really need to understand the member very, very well. What are the barriers? If you can get some of the consumer data, which is it's not really expensive nowadays. So that consumer data can really help you understand what's going on with the member. Build the member 360 first before you start using some behavioral health models. I'm sorry, not behavioral health, behavioral economics models. Sorry.
Yep.
So that my experience. And what I learned over the years is make sure it's all about the data and get it at the right time, because a lot of social determinants of health change over time. They're not static. So it's very important that you have the right data and good quality data first. Now, we are moving into using more and more behavior economics models. Like I said, by the way, this is a great question. In 2014, we started developing, like I said, the REI model, the risk, engagement, and impactability model. And actually what we're doing now, we're adding a B to it. So the behavior economic. So actually it's a four-dimensional model that we're moving towards now that we're collecting more and more member data at the person level. I want to go back to something that Logan and Kempton touched on too. Why is this important? When you're trying to create an initiative, a campaign to close gaps in care, you cannot have one size fits all. So everybody has different issues. You can't just call everybody or send everybody a letter. That's not going to work. It's going to work for one subsegment. And maybe it's going to, if you do it that way, actually will exacerbate the discrepancy between the people that have social risk factors and don't have social risk factors. Because, for example, you send an email. Well, who does not have an email? Right? So if you do it that way, if you do like a one size fits all, actually you could be making the problem a lot worse. So it's, I can't tell you how important it is to really, before you do a campaign, to understand who are the people who are you are highly likely to touch with that campaign, and are you making the problem worse if you do that?
That is a great segue to my next question. That was great. I wanted, for the rest of the way, I know we're getting tight on time, everyone. We're going to talk about innovation and implementation. So there's going to be some really good stuff coming up here. Last request for feedback. Well, second to last, that survey I talked to you about is already in your inbox. So that's one. But couple of things real quick. So if you're familiar with the show, my company, Share Purpose Connect, produces this show, and our job is to bring healthcare leaders together to collaborate. We do a lot of that through Bright Spots in Healthcare, but we're also starting what we're calling these leadership councils. We're bringing together health plans and select solution providers to talk about key issues like HEI and pharmacy. And we just started one around Medicare Advantage and innovations in that space. And we've got 9 health plans involved already in that council. I would love to tell you more about the councils when we have more time. And if you want to get some more information from me, even get on the phone with me and talk about it, I'd like to know, because these councils, these private, like sort of meetings that we're organizing on a regular cadence is really proving to push the envelope around collaboration and dialogue in a much smaller, more intimate, private form. And so that's one I wanted to ask you if you wanted to learn more about that. And the second is I have a really exciting episode for you next week. It's not healthcare specific, but it is. I'm bringing in a former general manager and executive from the National Football League. His name's Mike Lombardi, and he's going to talk about some of the best practices in leadership that we can apply from sports over to healthcare. I've talked to Mike. He's got incredible, interesting stories. You don't have to be a sports fan to get value from this. This is all about if you are a leader or looking to become a leader in your organization. This is a can't miss episode for an hour next week at this time, 12 o'clock. If you want to join us for that, you're going to get all kinds of anecdotes and stories about Bill Belichick and Bill Walsh and just other NFL legends who are just esteemed, proven leaders, and how this could be applied to healthcare. It's going to be a really cool conversation. I'm personally looking forward to it a lot. So those are my two questions for you. Back to the show. I want to circle back to just the policy changes we're all facing and why we're on the call today. Bring in Logan Fox again from CareSource. Logan, staying with innovation as the theme, can you provide an example of how you guys are creating new processes and programs to the ilk of just Amin setting us up perfectly, resulting from these regulatory changes from CMS, and how you are trying to ensure that you're not missing anyone and you're customizing things in a way that you're not missing anyone, sort of how Amin set us up for this part of the conversation.
Absolutely, and thank you for that question. So we have been able to innovate and take care of these members in great ways over the past several years. And one of those programs that I am so excited to highlight is CMR changes in the final rule are definitely going to impact us, but maybe not as much as some other organizations. We've always had an expansive MTM program, and we actually even by default at this point target members beyond the standard CMR criteria anyways. One of our dual populations, we were seeing that members had an uncontrolled A1C, so their diabetes was uncontrolled, but for some reason, and we didn't know why, they were not meeting the criteria for CMR targeting, that comprehensive medication review that would be provided by a pharmacist. So there's this discrepancy between someone who has uncontrolled diabetes, has medication therapy problems, but they're not qualifying for that comprehensive medication review, so they're not even given a chance for a pharmacist to identify and resolve those problems. So we created a program that goes beyond that CMR targeting and looked at anyone who was excluded from CMS criteria but had an uncontrolled A1C. And we connected them to pharmacists. We made them eligible for the review. And in this first project, we actually did it all with our internal pharmacists. So these internal pharmacists knew these people have an uncontrolled A1C. It's elevated. There are drug therapy problems related to their diabetes. Your job is to find them. And so we were very successful. On average, we had 3 or more drug therapy related problems that were identified and communicated over to the provider groups so that the problems could be addressed and the changes made. We saw that as primary outcomes, our members were, if they had the review, they were more likely to get retested for their diabetes. And when they were retested, their A1C was lower. And we categorized that by like the GSD measure stratification for the lowering. And we also analyzed who these people were. And they were people who lived in higher risk neighborhoods. They were more likely to be African-American males. They often had multiple chronic conditions that were just being untreated, probably due to access, because the CMR criteria is based on access to care. And these people did not have access. They were in need of this care. And we were able to directly address these discrepancies head on and take care of our members.
I love it. And far be it for me to preach to everyone, but I do a lot of these conversations. I get to meet a lot of folks in the industry. I would say one of the fundamental themes and differences I hear from the 5-star and 4-star plans is they take the regulations and they look about how much farther they could go beyond what's required at a minimum. That's a perfect example of it. How would you build that program? Like, let's put you in. Let's take you from CareSource. I hope your superiors aren't listening. I'm going to plop you down in another market. Let's put you in Missouri. We won't name the health plan that's paying you a lot of money to go there, but you've been hired, Logan, to start another program just like that. Can you outline a blueprint and how you would do that at another health plan so our listeners could take some notes right now?
I don't know if we would be able to just copy and paste the same program because I'm not at that other health plan and I don't know how their MTM program is structured, what vendors they use, if it's insourced, outsourced, if we're doing mostly telephonic or community pharmacy. And all of those will play a big role in that. But what I can tell you is we have also applied the same type of strategy to some additional markets within CareSource as well. So like I said, we provide comprehensive medication review services to our Medicaid members in all of our markets as well. But they don't have to go by that same CMR criteria. So we took some other disease states. So if they had uncontrolled A1C, uncontrolled blood pressure, or uncontrolled asthma, we use that as our objective targeting criteria for the Medicaid markets. And so it's not access-based anymore. It's using that objective criteria to say, you have drug therapy problems, we need you to go and fix them. And we didn't have all of the resources internally to be providing all of that. We relied on our community health partners out in the community pharmacies to be able to provide these services, pay them the extra dollars to take care of these members. And I think that when we compare those two different major initiatives, mostly with the same goal of trying to get people who typically wouldn't have been connected to pharmacist services and resolve these problems for them, I think that they both provide good examples of how flexible that can be, going beyond those regulations and thinking, who are we leaving behind and how do we make sure that we're not leaving them behind? And then what infrastructure do we have in order to address those gaps?
Okay, so let me try to summarize, and you keep me honest here. So I'm going to try to if I'm creating from my notes a blueprint here. First, who qualifies? Who qualified for the via the CMR? What was the infrastructure that you needed to enable to complete that CMR, right? Then you need to measure that gap. That was so important that you guys did on who qualifies for under the CMR and where there could be additional gaps. You figured out there was a huge gap with African-American males, A1C over 8. So that's identifying where the medication optimization opportunities are. And then from an infrastructure standpoint, you said 2 or 3 things. One, you need a CHW team, whether they're a team that you own or a partner with a CHW company, to connect members in the community with pharmacists. And then you have to hire and build that specialized pharmacist team so that they could deliver on that. Those were sort of like the 5 or 6 points that I wrote down. Did I capture everything?
I'd say you did a pretty good job.
Okay. Sure. If I chime in if I missed anything. Kempton, I know we're cutting a little close on time here. I want to ask you the same question around engagement and equitable access and medication adherence. We've heard a couple of programs that you have in place, or your health plans that you're supporting have in place. What would be sort of the core pillars that you'd recommend listeners put into place to do something similar?
Sure. So to use your USA Today kind of framework, the best way to kind of encapsulate what I would do and what I think would be successful in a newfound plan or in kind of a new initiative would be identification, intervention, and impact. So when you think about what you need to do in terms of understanding those populations, identification is bringing together all the data points that you have. First of all, much of that is claims data, eligibility data, finding a common thread amongst each member so you can get and marry up disparate pieces of data, match keys, other things. Put together a comprehensive profile for all your membership and then roll that into your population view so that you can really size up the hand that you're dealt and the risks that exist there. You can also decorate each of those profiles with external information like CDC data and other kind of quintiles that exist throughout the public repositories. And from there, it's very much about using that information to prioritize who to intervene with. right? And so much of kind of understanding how to run a viable and economically sound plan involves not only who are you going after, but who are you not going after? Who are you just monitoring? And so that prioritization on the front end is super critical. Consistent with what Logan said, I don't think, the CMS prioritization isn't exactly what you necessarily want to do. You want to build a program that is agnostic to certain measures, and it's the right thing by the population and the membership. And then along the way, you satisfy measures, right? So that you're not, at the whim of every regulatory change that happen every year, right? So you're able to have something that is about closing gaps and changing the trajectory of health. So you've got identification, you've got intervention, which is building the optimal engagement strategy. And as Amin mentioned, you don't want to be tone deaf and do the same type of outreach to every type of person. You want to use multiple modalities. You want to take the propensity of certain populations to respond to a call versus a text versus a fax to their doctor versus a live engagement bidirectional versus a health fair. You want to think about meeting that measure for measure, and then ensuring you get that motivational moment where you can make the change for that patient. You can help meet them where they are. And many times those issues that they're dealing with aren't medication related, they're more fundamental. And if you can handle and address those issues, the medication piece is just a positive byproduct. And then finally, impact, having a mechanism to measure what you've done. And you kind of have to frame the impact piece first, because you got to understand where you're going before you set off on all these initiatives. So understanding what your goals are and the KPIs you're going to measure, and using claims-based evidence as well as other types of kind of foolproof systematic views of whether you're actually moving the needle, so you can determine whether you're effective and whether you need to keep channeling resources that way. So sorry, Eric, just
right. I you know what strikes me, folks? I'm going to do this because I know everyone's getting the survey email, and some of you are going to ignore it. I just came up with this on the fly. My team's going to freak out. I've been taking notes. My notes aren't great, but they're okay, and I took a lot of those just now. If you want my notes from today's show, anyone that fills out the survey that I just emailed you, I'm going to send you a copy of my notes. It's a Google Doc. I'll convert it to a Word document. It's sloppy, but I got a lot of them in there. So I'll email that to you as a thank you for filling out the survey. Thank you all for tuning in today. I know you're really busy. I know when you take an hour with us, whether you're on a walk at an airport right now or you're watching live, that it's a valuable time. I do not take that lightly. I hope you use the bright spots shared today to inspire your thinking, enhance your organization's approach to improving healthcare for all of us. Thank you to our panel. Great job preparing, great job participating. Really thank you for your time and the extra effort you put in there. Subscribe to the podcast, rate the podcast. We produce this show for you. Remember, this is your Bright Spots in Healthcare podcast. Take care, everyone.